Good afternoon, everyone. My study is on IOL prediction errors in eyes with axial length less than 22 mm, a retrospective study. Prediction error is the difference between the predicted post-operative refractive error and the actual achieved post-operative refractive error. Short axial length eyes remain challenging for IOL power prediction because small errors in effective lens position estimation translate into disproportionately larger refractive surprises. My aim was to compare IOL prediction errors of SRKT and Barrett IOL formulas in eyes with axial length less than 22 mm. My study sample included patients aged more than 18 years who underwent cataract surgery, both SACS and phacoemulsification surgery, although 90% of my cases were phacoemulsification surgery. A total of 120 eyes were selected in that it was divided into 60 eyes with axial length 20 to 22 mm and a control group of 60 eyes with axial length 22 to 24 mm. And each groups were subdivided into 30 each with the IOLs with SRKT formula and 30 with Barrett's IOL formula. And the exclusion criteria was the combined procedures like trabeculectomy with cataract, SOR with cataracts were excluded, and any combined procedures with cornea procedures were also excluded. And the post-operative best corrected visual acuity less than 6/9 were not included, and any cases with intraoperative complications were also excluded. This was a retrospective study which was done in a tertiary eye care center in Kerala. The cataract surgery was done by a single surgeon in the period of 2021 to 2024, and preoperative data was obtained from the optical biometry done before cataract surgery, and the spherical equivalent for the IOL power used for each surgery was noted. Post-operative subjective refraction at 2 weeks was assessed, and the prediction error was calculated by the difference between predicted spherical equivalent and the spherical power of post-operative subjective refraction. And coming to the results, we can see in axial length less than 22 mm, there is a significant predictive error, statistically significant difference in the predictive errors between Barrett and SRKT formula. And in the axial length greater than 22 mm, there is no much significance in predictive errors. There is no difference. And in the group of SRKT, the eyes with SRKT IOLs, there is a statistical difference between the axial length less than 22 mm and more than 22 mm. But in Barrett's, there is no much difference. This is the line diagram showing the trend of prediction error. The orange line indicates the SRKT formula and the blue line indicates the Barrett's formula. We can see as axial length increases from 20 mm to 24 mm. The SRKT, the prediction error in SRKT formula decreases, but in Barrett's there is no difference. So the Barrett formula demonstrated lower and more consistent prediction errors across both short and long eyes, wherein SRKT formula showed a higher error in short eyes, indicating that Barrett performed better in eyes with short axial length. So coming to the discussion, in a larger short eye series with axial length less than or equal to 22 mm, Project Hyperopic Power Prediction reported that many earlier generation concepts, including SRKT, tended towards myopic outcomes, whereas newer methods mitigated this bias. Srivastava et al. Found that in axial length less than 22 mm, newer formulas outperformed earlier ones. The SRKT showed larger errors than contemporary options. A recent review synthesizing short eye evidence reached similar conclusions. Short eyes are at particular risk of myopic prediction error with older formulas. Performance improves with formulas that better model effective lens position and use additional anatomical inputs. My limitations were the number of eyes included was limited, which may reduce generalizability of the results. Being conducted in one center, the outcomes may not reflect wider population variations. Only two formulas, SRKT and Barrett Universality formulas, were analyzed, whereas newer formulas like Hill RBF, Kane, EVO 2.0 could have provided broader insights. By doing this study, we came to the conclusion that although no single formula can be considered universally optimal in eyes with axial length less than 22 mm, Barrett University appears to provide a practical advantage over SRKT and should be preferred when managing short eyes. Our findings reinforce that short eyes require careful formula selection, and constant optimization and individualized formula choice remain essential to minimize refractive surprises in short eyes. Thank you.
these patients?
No, ma'am. Mature cat base scans were not there. The fundus evaluation was only done.
Okay. The importance of doing the base scan is looking at the RCT thickness,
Okay.
and we also look at the extreme eyes, we call them as very short eyes and very long eyes. So we do a B scan, and the axial length again less than 22. We are always careful with eyes less than 18. Okay.
Extremely low was not there, ma'am. Less
Oh,
than 20 were not there.
you didn't
But
have, or you didn't check?
we did have, but it was very like I couldn't get it as a sample. Like 20 to 22 were only included in my study.
Included means you never had patients less than 20.
We had, but I mean I didn't include those.
So then short eyes, you can't call them as short eyes.
Like shorter, larger short type, like
Because the title is only less than 22
22
millimeter.
mm. Only 20 to 22.
Yeah, it could have been classified as maybe 18 to 20 and 20 to 22. So, yeah, that's what.
So why did you not use Hoffer Q as a comparison? Because usually, traditionally, we say that is more accurate in short
Yeah,
eyeballs.
it is said Hopper Q is more accurate. But ma'am, my surgeon, like it was a retrospective study. So my the surgeon which I took SRKT as a better formula, and I just went through the Hoffer Q calculations also. The IOL powers were almost comparable, like maximum 4.5 difference was coming, the difference of IOL powers. So, but I didn't make an analysis on that.
Thing is the generation of the formulas, whereas you club the SRKT and Hoffer and
Yeah,
Holiday and all into the older formulas, whereas Barrett's is a newer generation comparatively, and then further down is the Kane.
Okay.
So when you compare, ideally it could have been between
Same
Hoffer
generation.
Q and
SRT.
Barrett's. No,
Barrett's, okay.
SRKT. Okay, yeah, if that way, because between SRKT and Hoffer Q, we know that Hoffer Q is better. So when you compare Hoffer Q with Barrett's, you will know whether Barrett's is still doing better. So in which your center, you are placing the IOL based on which calculation?
Barrett's formula now.
Barrett's. Yeah. So
Previously it
universally,
was,
many centers have totally shifted to Barrett's in the adult intraocular lenses. So I think then that comparison might have been more useful.
Ma'am, this is done like with the 2021-22 SRKT was preferred at that time. Barrett's were not into use. So now after 2022, we started using Barrett Universal too. So I made a comparison like that.
Okay.